Here we go. Here we go. Right? Sutures of the skull. Right? The skull has seams. The skull is made up of 22 different bones that all form together. Right? And then as we get to be an adult, remember the baby's got the soft spot up here, the fontanelles here and here. Right? And so, sutures of the skull. If we look at the skull from straight on, right, there's one across here. Yes, note they're crooked, right? They're wavy. Yes. Okay. Across here. Right across here. Yes. And that's an easy one. That's an easy one. That is, when you split the body in the front and the back in your planes of the body, that's called what? Coronal, right? So that's the coronal suture. C-O-R-O-N-A-L, coronal, right? Yes? Oh, by the way, if you split the body right down the middle, that's called what? Mid-sagittal, right? So the one across the top that goes right to the back, that is mid-sagittal, or sagittal or mid-sagittal, whatever. Yes? Okay. Now, okay, if you look at it from the side, yes, you got coronal coming over here, and then coronal hooks up with one that looks like that, curved, like that, comes across and joins this one back here. Yes, that is squamous, S-Q-U-A-M-O-U-S, right? Remember, squamous epithelium looks like a, what? A fried egg, yes? This is squamous on the side. It's right there. Okay? Right? Now, if we look at the skull from behind, posterior view, yes? This is the back of the skull. You got one across here. Right? Remember this bone down here is the occiput or occipital, right? Well, this one across the back here is called, it's the only hard one, lambdoid. L-A-M-B-D-O-I-D, lambdoid. Okay? Right? So, there will be a question on the test of the sutures of the skull. Let's go over it again, right? You split the body from the front and the back. That's a coronal section, right? So this suture all the way across the top, right? That's coronal, right? Oh, by the way, sagittal, right? Yes. You got one on the side here that's curvy. Curves up. It's shaped kind of like that, right? It's squamous. Squamous. And from the back, okay? Here, let's look at them right here. Here we go. See? Starts over here, comes all the way over the top, right? Coronal. Sagittal, right down the middle. On the side, see the curvy right through there? Shaped like that. Curvy, curvy. Squamous. Squamous. And across the back. This is the occiput here. And this one right here that comes up. It's kind of shaped like that. And again, all the sutures are curvy. Suture literally means seam. Seams of the skull, right? Sutures. Yes? Right? Okay. So, real simple. Coronal, mid-sagittal. You already should know those two. Squamous for squamous, because of the shape of it. And lambdoid. That's the only hard one that you're not familiar with. Lambdoid. Right here. Right across the back. Starts over here. Up and down. And again, this is the occipital bone. That's the occiput. And right there. That shape just like that. Like a C. Pointed down. Lambdoid. Okay? The lambdoid. Right? There we go. Okay. All right. Now, Lord, that took a long time to do all that. But anyway, here we go. Let's start chapter 8. Okay? Any questions before I start? Now, to everybody, I need you to listen to me real carefully. Okay? When the test will be multiple choice, and true and false. I'm talking about the lecture test. We'll also have the lab test, right? We'll talk about that. I haven't made that one up yet. Okay? Now, whenever you're taking a test, if it's multiple choice, right, then you need to relax, right? Because you read that multiple choice question and it's usually A, B, C, or D, yes? Almost immediately, boom, you know two of them aren't right. So you're down to 50-50, okay? Read the question clearly, throw out two of them and know it's either this one or that one, right? You got a 50-50 shot. Now, if you know it, or you think you know it, okay. Don't sit there for 10 minutes. Oh God, it won't come to me. You're wasting your time, okay? You need to pretty much pick one and then move on, all right? Usually, your first guess is your best guess. Not always, but usually your first guess. If you sit there and think and think and think and think, you'll talk yourself out of it, right? Right? Usually. Yes?
I did that on the...
Okay. Right? Yes? If I'm lying, I'm dying. But anyway. Okay, number 2. There's true and false. I use those. Read the true and false questions slowly. Okay? True and false usually turns on one word. Right? One word. Make sure you read the question slowly. Think about it for a minute. And then true or false. Okay? Bring a pencil and an eraser. Okay? Now, I need to tell you this. It'll be a blank, 1, blah, 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 A, B, C, D. I need a capital letter, capital A, or a capital B, or a capital C, or a capital D. They're much more easy for me to interpret. If I can't read it, guess what? It's wrong. Sorry, that's just it. Capital A, B, C, or D. In the blank. If you come over here and you circle this, oh great, Guess what? You didn't put it in the blank. If you didn't put it in the blank, guess what it is?
Wrong.
Wrong. Right? Because you didn't follow instructions. Right? You don't follow instructions in the Marine Corps, bad things happen. Okay? Right? I need a capital letter in the blank. And some of them will have this, T or F. T or F. I need this one circled or this one circled. Right? That's why I want you to bring a pencil, because sometimes you change your mind. Yes? But most of the time, you can eliminate 2 and pick which one of the 2 that you really think it is. But do not overthink it, right? It's called analysis paralysis. Yes? Right? Yes? I spent 14 years. I was on the fencing team. Yes? And we wear the masks. And you always look at the guy's chest and where his arm is. And you always look at his face too. Right? Because if you catch him thinking, then you do this. Wah! And you stick him right quick. And then you say to him, oh, caught you thinking. Right? Because he's going, okay, I'm going to do that. Yes? The moment I saw that, I attacked him. Surprised him. Got him. Yes? Analysis paralysis. Yes? Right? Before he was ready. See? So, anyway, think about it. Choose one. Move on. Okay? That's the way it works. You're going to get your best score that way. Yes? And again, remember, I grade on the curve. It's a very long test. 72 questions. If you miss 1 or 2 or 5, don't worry about it. Right? Because there's 72 of them. Yes? More important, it's not as important how many you got right, it's how many you got right compared to your neighbors. Right? So realize that. You study harder than your neighbors. Right? Okay? because it's a bell curve. There'll be grades down here, and there'll be grades up here, and there'll be a few grades over here. That's the way it goes. Yes, but it's graded on a bell curve. Okay? So, right? And again, it's a very long test. It's going to take me like 2 hours because there's so many of you guys to go home and grade it. But anyway, oh, by the way, I need to leave, Ariana. I need to leave. I have all your article done. So you all made pretty decent grades. And a bunch of y'all made really, really, really good grades, okay? Because you gave me what I wanted, right? A good paper that was long enough, that had very good typing, very good grammar and syntax, and most of them were very, very good, okay? So most of y'all are going to get a really good grade, okay? A couple got an okay grade. Nobody got a really bad grade on it, right? And before they changed the computer system, it would have been in 2 days ago, but I can't work this new system. So I'm going to get Miss Lexi to put all the grades in, so you'll be able to look for it as soon as she gets them in. But they're all graded since yesterday. Okay? No, since Friday. Yeah. Okay? Okay. Anyway, right? Relax. I am going to have you spread out too, because we got more room here. Right? When we take the test, I'm going to have you spread out. Yes. We'll also have a lab test. The lab test, I know we're going to have the parts of the microscope. I need to make some notes for myself. Parts of the microscope, super simple, right? Finding course adjustment, arm, base, light source, ocular objective. What piece? Nose piece, right? Yes. Okay. It can't get much simpler than that, right? So, right? Not eyepiece. It's not eyepiece. It's the ocular. Yes? Okay? Okay. Now, Chapter 8. Chapter 8 is very interesting to me because it's joints, and I'm a joint man. I think joints are cool. We can play sports, we can jump up and down, we can water ski, we can surf, we can ride motorcycles, all because these amazing joints, right? And joints are classified in different ways, okay? They're classified as to their structure, right? And they're classified to their anatomy and such. And so we're going to talk about that, right? Also movement. Okay, here we go. Synarthrodial. Synarthrodial. A-M-P-H-I. Amphiarthrodial. Diarthrodial, okay? Synarthrodial joints, right? Synarthrodial joints are joints that don't have motion in them, okay? Immovable joints, right? S-Y-N, that's what it means. Immovable joints, right? Our example of that would be the sutures of the skull, right? The sutures of the skull, immovable joints, right? Synarthrodial. Notice, S-A-D, sad. But anyway, synarthrodial. They're hooked together, they don't move. Amphiarthrodial is partially, right? Yeah, slightly movable. S-L-I-G-H-T-L-Y. Slightly movable. Fib, yeah. Tibia, fibula, okay? If you look at the fib down here, yes, right. This is the tibia, the thicker bone. This is the fibula. This bone right here, yes? It's tied together with powerful ligaments. Is there motion in here? Yes, there's a little bit of motion in here, but not much. Okay? So it's amphiarthrodial. Okay? Amphiarthrodial. That's our example of that. Okay? It moves a little bit, not a lot. Okay? It's tied together with ligaments. It's a levofibrous joint. Okay? We'll talk about that in just a minute. Okay, diarthrodial is freely movable, right? Freely movable, right? Diarthrodial joint. Diarthrodial joints are the joints in our extremities, right? Check it out. Yes? Freely movable, right? Freely movable. Diarthrodial joints are cool. You can ride a skateboard because diarthrodial joints, right? Yes? Because they can do amazing things, right? Synarthrodial sutures of the skull, pretty boring. They just sit there and don't do anything. But your elbows and your knees and your hips, right? Yes? Okay. So, that is a functional, how they function. That's a functional, F-U-N-C-T-I-O-N-A-L, functional classification. Yes? Now, let's talk about a structural, their structure. S-T-R-U-C-T-U-R-A-L, structural classification. Structural classification, right? Yes? Number one. Okay, structural classification of joints focuses on the material binding the joint, and is there a joint cavity present, right? A, fibrous, F-I-B-R-O-U-S, fibrous, yes? Okay. Fibrous. One, sutures, right? Let me explain, right? All these sutures in the skull, there's tiny little pieces of like a ligamentous material that holds those sutures together, right? It's a fibrous joint, right? Syndesmosis, S-Y-N-D-E-S-M-O-S-I-S, right? Okay, syn, S-Y-N, that tells you right there it doesn't move very much, right? Yes? Syndesmosis, yes? That's like your tib, fib, okay? Right? I was saying at the tib fib right here, you have powerful ligaments that tie that together. Yes? This fibula down here, that fibula, yes, you can wiggle it a little bit, but it's tied together by powerful ligaments, right? And so it has to be because it acts like a strut. It helps us to walk, okay? Okay, also interosseous membrane, okay? Interosseous membrane, okay? Check it out. Cooperate, dude, come on. Okay, right? This is your radius and your ulna, your radius and the ulna, right? And the head of the radius is round and it pivots. It's a pivot joint. We'll talk about that in a minute. See, just like this. But in between these two, guess what? There's a sheet of ligament called the interosseous membrane. It's a sheet of ligament that ties this bone to this bone, okay? Oh, by the way, guess what there is in here too? Interosseous ligament, okay? All right? Now, there we go. Right there. Okay, in my book, let me give you the page. There's examples of all these that make it very simple, okay? Figure 8.1, the fibrous joints. Figure 8.1, okay? A syndesmosis, right? The joint's tied together. It's tied together by powerful ligaments, right? Okay. And the third one is a gomphosis. Gomphosis. Gomphosis, right? There's one guy who deals with those, right? Yes, and that is your dentist, right? That's a ligament. It's like a peg in a socket. There's a powerful ligament down here, right? A gomphosis. The only one who deals with gomphosis are the dentists, right? Gomphosis, gomphosis, right? If you look, figure 8.1, it shows you the sutures, the syndesmosis, and the gomphosis, right? And those are the fibrous joints, all right? The fibrous joints, yes? Okay. Cartilaginous joints, Cartilaginous. Cartilaginous joints, right? Cartilage hooks that joint together. Okay? And there's only two types of those. One, synchondrosis, right? Okay. That is your epiphyseal joints, your epiphyseal plate, let's put it that way, epiphyseal plate, right? It's also the first rib to the sternum, okay? Now, syn means it doesn't move very much. Chondro means cartilage, right? It's cartilage and it doesn't move very much, yes? Remember the long bone, yes? Right? Here's your epiphyseal plate on the end of the bone, right? It's your growth plate. Is that growth plate supposed to move? No. The growth plate is supposed to do one thing, grow, make your bone longer, right? Yes, it's not supposed to move. If it goes this way or that way, bad news, you're having surgery. They're lining her back up and putting a screw in it, right? Yes, you're having surgery, okay? So it's a syn, it doesn't move very much. Chondro, that's made out of cartilage. That across there, right? Remember, epiphyseal cartilage. The growth plate, the epiphyseal plate, I should say, okay? Now, the other type of a cartilaginous joint is a symphysis, Cynthysys, right? And that is your discs and your spine and your symphysis pubis, right? Okay? That's your symphysis pubis right there, where the two bones come together. That's a cartilage joint. That joint between these two are united by cartilage, right? That's a cartilaginous joint, yes? Now, these are the joints in between your vertebrae, right? Right? Those discs. And those discs, did you get it? Oh, here it is. Here it is. And those discs are actually classified as a symphysis tube, right? They're cartilage. Here's the top vertebrae. Here's the bottom vertebrae, right? And in between there, right? The discs. Now, they do move a little bit when we do this, right? When we go forwards and backwards and left and right, but not very much, right? Okay? And such. Remember the outer part is the annulus fibrosus. I need to know that for the test, but I'm just saying. And the middle is a nucleus pulposus, right? So that is a symphysis, right? And the symphysis pubis is where the two pubic bones come together, that, right? They're both fibrocartilage, by the way. Yes, remember? Okay. So where am I at now? Okay. Okay. Yes. Now. Cartilaginous joints that don't hardly move. Cartilaginous joints that move a little bit, but they're tied together with cartilage. The symphysis, the two types of unusual, right? Now, we're going to talk a whole bunch about synovial joints. And synovial joints are the ones you think about when you think about joints. Your knees, your elbows, your fingers, your toes. Those are all synovial joints, right? Synovial, synovial joints. Okay? Synovial joints are very special. They're very unique, right? They are freely movable. Freely. Freely movable. Yes, right? You can move your elbow. You can move your knees, right? Your limbs. Okay? Now, our example is going to be the knee. Here's the knee. Right? Yes? Okay. Now, they all have what's called a synovial cavity. Around this knee, you have a bag. You have a bag, right? It's a joint capsule. That is one of the hallmarks of the synovial joint is the joint capsule, right? It's 2 layers. The inner layer is a synovium, and it secretes a synovial fluid. The fluid in your joints is synovial fluid, right? Synovial fluid, right? Okay? Okay, number 1, articular cartilage. Articular cartilage is hyaline most of the time, right? Articular cartilage, usually it's hyaline, okay? On your fingers, on your toes, your elbow, okay? Articular cavity, A-R-T-I-C-U-L-A-R, articular cavity. What does that mean? Right? In here, you got that bag, and inside that bag is considered a cavity. It's articular cavity, that's where the articular fluid is, right? Yes? Now, you don't have that at your symphysis pubis. You don't have that at your spinal discs, right? You don't have that at the first rib to the sternum. You have it here in these fingers and elbows and knees. It's articular cavity, okay? Number 3, articular capsule, right? This bag is called, okay, I wrote joint capsule, but they're saying articular capsule. Same difference, okay? Number 4, synovial fluid, right? Synovial fluid, right? Inside this joint, there's fluid. In your spinal discs, are there fluid? No. In your pubic symphysis? No. In your tib fib, is there fluid in there? No. In the knees and the elbows, in between the fingers, you got the joint capsule, and that inner lining is the synovium that creates the synovial fluid. Synovial fluid, you ever crack an egg, the white of an egg, and you feel it's all slimy? Same difference, just like that, right? Right? It's made out of water from the blood, but also protein, right? Very slick, very slimy, about as thick as motor oil, okay? Synovial fluid from the blood, viscous egg white due to hyaluronic acid, okay? Now, so far this hasn't happened to me, thank God. But tons of patients come into my office and tell me this. Man, I just wake up in the morning and I am so freaking stiff. I can't hardly move. And then I get up and I walk over, and my knees hurt, and my back hurts, and I walk over and I make my coffee and I sit down and I got to moving around. About 30 minutes later, I'm pretty good. I'm good for the day, right? Yes? Okay. That's synovial fluid. When you lay down at night, it's about as thick as motor oil, okay? As viscous as motor oil, right? But then what happens is that you lay there all night long, it gets almost as thick as Jell-O, okay? But then I had one lady tell me, she said, oh yeah, I wake up, I can hardly stand on that knee. And she said, and then I go down the hall to change the thermostat, right? She said about most of the way down the hall, and all of a sudden then I can walk again, right? Yes? Because by moving the joint, you make that nice and fluid. You make it like motor oil again, right? It's called the gelling phenomenon, yes? Right? Now, you got to be careful. The medical guys want to give you something like Motrin. Oh, just take 2 Motrin every morning, right? Not a good idea. Not a good idea. Because, if you bung your knee and you take it for a couple of days or a week, okay, that's one thing. But you take it for long periods of time, it kills your kidneys, right? By the way, the NSAIDs, non-steroidal anti-inflammatory drugs, which one works the best? According to my good friend, Gary Johnson, the pharmacist, which one works the best? You can buy it over the counter. Aleve. Aleve is naproxen, right? Naproxen works the best. That's what Gary tells me. He ought to know. He's got decades of experience. It works the best. It's the hardest on your kidneys, by the way. You start taking those, you better be drinking lots of water. I'm just saying. And you better not be taking it every day for long periods of time, because if you are, you're killing your kidneys little by little. And the thing with the kidneys is you get really bad and they're about to collapse before you have any signs or symptoms. It's very serious. Kidneys they're silent, right? It may be years they're giving that silent scream, but you don't hear it until all of a sudden you go into kidney failure. It's way bad. But anyway, sorry. Okay? So, reinforcing ligaments. 5, reinforcing period. Ligaments, right? This joint capsule, it's anchored with ligaments that help tie it down. It's been one of those days all day today. You know that? Yes. Okay. 6. Nerves and blood vessels. Right? Okay. To this joint capsule, you have nerves. Right? You have nerves. Yes. And you have a blood supply to that. Okay? Again, that's where the synovial fluid comes from. It comes from the blood, right? Yes? Now, nerves. Okay? Okay? Yes. Right? Could you come up here? I need a victim. A volunteer. Yeah. Yes? Okay, sir? All right. Now, this guy, right? He's big, he's stout, he's strong. Yes? Elbow moves really good. Yes? Elbow's supposed to do this or that, right? Yes? Yes? And the only thing is, if I come around like this, right? Yes? Okay. Hang on, let me get a better grip, right? Right? If I do that, it's not supposed to go that way. Right? If I do it hard, would it hurt?
Probably.
Probably? Okay. What I'm saying is, that joint is being stretched, that joint capsule, right? And if I do this, I can take a great big man and put him on the ground if I catch him quick, if I'm quick enough, right? Yes? Because the joint not supposed to move that way, and I'm stretching the front part of that joint, and I'm compressing the back part. Yes? Yes? So, thank you, sir. Now, let me think of it. Okay. Right? He's a tough guy. He grabs me. Yes? If I do this, right? Yes? Hey, I didn't catch it right. I'm out of practice. Okay? Again. Hang on. Yes? Yes. Okay. All right. Sorry, he wouldn't go, so I had to show him. Right? Yes? Okay. Yeah? This guy comes up to me in the park like, oh, that karate crap, does that really work? I said, I don't know, grab me. And he grabbed me and I did this. And he was on the ground, he left immediately. But anyway, yeah. See, I put that joint in a place it's not supposed to go. Right? I stretched on those nerves and those ligaments. Yes? Okay? Right? Okay? One more. This one won't hurt, I promise. Okay? Take that arm right there and right? If someone grabs you, ladies, yes? Notice he's got 4 fingers and 1 thumb, right? And they have your arm, okay? Right? The simplest thing is twist the arm this way. See how his thumb and his fingers are meeting, right? Yes? And you pull it out. Grab me again, right? Okay? Here. Yes? He's a strong guy. Hang on, okay? Don't really see, right? Okay? He's a strong guy. Okay? Yes? All right, here we go. One more time. Oh, he is a tough guy, yes? But come on, that's the problem. That's the second move. Right? If they're not expecting it, now see, he knew that I wanted him to squeeze hard, right? But if he just grabs me, right, and I twist, and that's the second part. Immediately you whack him right in the nose. No, I'm serious. Yes? Really, ladies, you get grabbed, you go, wow, bam, right in the face. So, anyway, joint capsule. You stretch on it, it's got ligaments, it's painful. It's got nerves, it's painful. Okay? Nerves and blood vessels, right? Yes. I'm going to pick somebody next time who's not so strong. But anyway, okay, right? These are amazing, right? You got your synovial cavity. You got your synovium coming from the inside. You got your articular cartilage between the bones. You got your joint capsule, inner synovial, outer is fibrous. You have powerful ligaments around it to help support that joint. Did I miss anything? Articular cavity, capsule, synovial fluid, reinforcing ligaments, nerves and blood vessels. You got nerves and blood vessels to this, right? And remember, that synovial fluid, you got blood vessel to that inner synovium, and that's where the joint fluid is going to come from. That's what your body's going to make it from, the blood, right? And add some protein to it, hyaluronic acid, okay? There we go. Now, okay. Now, the knee joint is a really special joint. It has fibrocartilage in here, right? It has fibrocartilage in there. Somebody absconded with my trash can. Jeez. That's been in there for years. So, is there a trash can over there?
Yes.
Albert. Okay, thank you. Okay. So the knee is kind of special in that it has the menisci in here. That's fibrocartilage, right? Right? Most joints is hyaline cartilage, but particularly the knee, it's fibrocartilage, right? Okay. Yes. And remember too, that cartilage on the end of the bone is called articular cartilage. Yes. Okay. Okay, let's talk just a little bit about bursas. And that is, the picture of that is figure 8.4 in your book, okay? A bursa. A bursa is a fluid-filled bag. You have one in your shoulder up here, and when you do this, the bursa, here's the head of the humerus, and it's shaped kind of like that, right? And when you do this and that, it kind of moves forwards and backwards like that. Okay? It's a bursa. It's a, what word am I looking for? It's a spacer in there, okay? It helps with that. Okay? It decreases the friction between joint surfaces during movement. That's what a bursa does, right? And remember too, we talked about ischial tuberosity bursitis. You have one over here and here. They get irritated. Pardon me. This is greater trochanteric. Ischial tuberosity, you got one over here and here that you sit on all the time, right? Those bursas, okay? In the shoulder, yes? Okay. Tendon sheaths. A sheath is a long bursa, a tendon sheath. And mainly where you see that is on the biceps tendon, but also too, right? You got 5 fingers and you have all these muscles that run through the wrist, right? What makes the fingers work is the forearms, right? Yes? And you got at least 5 tendons running right through here. And those tendons have a tendon sheath on them, around them, so they'll slide back and forth and not have friction. And when you get scar tissue in between them, right? What does that cause? What?
Stiffness.
Stiffness, yes. Yes, but it causes generally this part of the hand to be numb and tingly and wake you up at night hurting.
Carpal tunnel.
There you go, carpal tunnel. And what do? They make a little slit here or here, and they'll go in there and they have an instrument shaped like that. And they'll take that instrument and they'll put it around that tendon and they'll then they'll go to the next tendon. And they'll go, and they'll break up all that scar tissue. That's what carpal tunnel surgery. Oh, by the way, does carpal tunnel surgery last?
No.
Usually for a couple of years, maybe, right? Depending on. And that's really interesting. We don't know exactly why carpal tunnel is so much more a problem. Is it because of computers, right? If you sit at the computer with the wrist cocked, right, it puts a stretch, right, on those tendons. Is that what does it? Is it because power tools, right? Shaking, causing irritation? I don't know. Many years ago, there was some research that said that if you're low in B6, you're more likely to have that. Research out of the University of Texas. But anyway, interesting. I don't know exactly. Okay? But anyway, tendon sheath. It's called a sheath because it's like, think about a hot dog bun wrapped around a hot dog, right? It's like a sheath. Yes? You have tendon sheaths through there. Yes? And anyway, yeah. I saw a movie once where they're doing the carpal tunnel surgery, and the guy literally had the instrument in there, and he's going just like this. Different tendon. I mean, he's working it. That was really interesting to see. But anyway, okay? Now, let's talk about this. Ligaments. Ligament versus tendons. Ligaments versus tendons, right? Okay, ligaments. Ligaments attach bone to bone. Tendons, muscle to bone, right? Muscle to bone, yes? Now, when I had Joseph's elbow just like that, right? It's not supposed to go that way because you got ligaments on the front of that elbow, right? Ligaments, write this down, limit motion, right? If you push your head back, it's only supposed to go so far back, right? Because ligaments on the very front, right, anterior longitudinal ligament, right, limits that. Now, I got my bicep here, and I got a bicep tendon, right? Yes? And the tendon attaches that muscle to that bone, right? Yes? And when that muscle contracts, I move my arm. So tendons allow movement, ligaments limit movement to certain things, right? Yes? Football players, legs straight, that's as far as it's supposed to go. And if you, bam, hit it that way, you hyperextend that knee, right? And you sure can tear the anterior cruciate ligament, yes, the ACL, right? That's one of the ways. There are many ways. But anyway, yes, because that knee is supposed to go straight, but it's not supposed to go further than straight, right? When that happens, you got major troubles, okay? But anyway, tendons allow for motion. Ligaments limit motion, right? Okay. Muscle tone. What does that mean? Muscle tone, right? Muscle tone, yes, right? Now, right? The bodybuilders want those big bulging muscles, yes? And some gals go for that, okay? But, right? You don't want someone who's flabby, yes? Right? Muscle tone is a slight amount of contraction, yes? Right? So we look fit, we look strong, we're ready to go, yes? Right? The linemen line up like this, right? They're ready to go. Their muscles are slightly contracted, and boom, they're going, right? Yes? Muscle tone. If I didn't have a certain amount of muscle tone, I would do this. Right? Yes? You got to have a certain amount of muscle tone to keep you standing. Okay? Yes? Are there many lady bodybuilders? Not a lot. When they get the big bulging muscles, Do you find that attractive, Mr. Albert? No? Right? Ladies aren't supposed to look like that. Yes, it's not natural. And usually if they look like that, they have real deep voices because they've been taking the roids, right? No, really. No, really. Yeah. I watched a video a while back, and it was all these men that were the bodybuilders, and they all died in their 40s and early 50s. And then there were 5 or 6 women that were fitness models like that were real muscular and all, and they too died of heart attacks in their 50s. It was just like, oh my gosh, that's not natural for women. But anyway, we have to have a certain amount of muscle tone to stand up, to be ready to go, right? Don't get me wrong, I don't want a flabby woman, but I don't want one that's, real muscular either. Yes? Right? Women that go to the gym, most of them they want to be toned. They don't want to be real muscular, right? So, anyway, okay? Muscle tone. Low level of contractile activity in relaxed muscles that keep muscles healthy and ready to react to stimulation, right? Right? The lineman, they're there and they're ready to go. Fencer, right? I'm ready to go. Boom. They said in fencing they would say fence, or if they were French they would say allez. That means go, right? So anyway, okay? Yes. Let's take a break for just a minute. I need a drink of water and run to the little boy's room.
I'm so concerned about that trash can.
Bless you. Ready. Okay? We're going to talk a lot about this. It's either the next chapter or the next, right? But when we talk about muscles, let's talk about origin, insertion, okay? The origin, the insertion, right? Okay. Okay. If you take my bicep right here, right? Origin, it starts up here, right? It originates up here. That's its origin. And the word insertion, right? Yes, from the same word insert, right? Yes? You fold up your letter, you insert it in the envelope, right? So, the origin is up here, and the insertion is down here where it attaches to the bone down here, right? The origin, the insertion. But it's really not, some people think, oh, that's the start of the bone and that's the end of the bone. Well, no, it's more complicated than that, okay? The origin, right, is the attachment to the immovable bone, and the insertion is attached to the movable bone. What? Yes. Think about this, right? Muscles pull on bones. We can move, we can walk, we can do all things because muscles pull on bones, and bones act as levers. Yes? And when I do this and my bicep contracts, right? This doesn't move. This is the immovable bone up here where it's attached. Down here, see that bone moving, right? That's inserted or attached to the movable bone. So this is the origin. This is the insertion, right? This is the movable bone. This is the immovable bone, right? Yes? Medial deltoid. Right? It's attached up here to the immovable bone. That's the origin. But it attaches down here to the humerus. And the humerus moves, right? So that's the movable bone, right? So this is the origin up here and the insertion down here. Does that make sense? Two bones, right? One of them is something to pull on, and the other one moves when it gets pulled on, right? So the one that doesn't move is the origin, and the one that actually does move, that's the muscle inserts there, okay? The origin versus the insertion, okay? We'll talk a whole bunch about that in a future chapter. But anyway, if you notice, I'll talk about some for a minute, and then another chapter or two, it'll come back again. Because if you hear it 2 or 3 times, you're much more likely to remember it, right? But anyway, okay. Pardon me. Types of movement, right? These are figure 8.5, yes? Our wrist. We have a gliding movement, right? Yes, we have a gliding movement, yes? Okay. When two joint surfaces do this and slide across each other, they're usually flat or close to flat, right? That's a gliding movement, mainly the wrist, right? Yes, do the queen, right? The queen does this, right? Yes, yes, she learned that. Look at that, she learned that when she's in the beauty contest doing. Do it again, show the rest of us, please. She had some wrist action there. Hi there, yes, okay, right? Like the wife, I go to her every couple of years. I go to the Mary Kay deal, and they all have their awards, and they go across the stage. And I swear, in one day you'll see over 1,000 women's armpits. Right? Yes. Sorry, it's true. Yes. But anyway, okay. Angular movement. Angular movements are where the angles between the two bones change, right? See, my upper and my lower arm. If I do an angular movements are, the angle is straight, 180, right? But if I do this, it's 90, right? Does that make sense? These two bones, the angle, either is getting closer together or further apart. If they get closer together, that's flexion. If they go further apart, that's extension, okay? Flexion or extension, okay? Okay. Abduction, adduction, right? Adduction, ADD. Adduction is where you take up something and it moves towards the midline. Add, right? ADD, see, I'm adding the arms. They come closer to the midline. Adduction, okay? Now, the opposite of that, if I have my arms here and I move them out, that's abduction, ABD, okay? Now, adduction, abduction, it's very hard to tell the difference. If you go to a conference of chiropractors or medical doctors, they will say adduction, and they will also say, if it's abduction, they will literally say that, abduction, abduction. So that way you can hear the difference. Adduction, abduction, adduction, abduction, right? But usually, I remember I went to this one as a lady orthopedic surgeon. She said to me, abduction, 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 right? Add, I'm adding to the midline. Abduction, opposite, right? Okay? So, adduction, abduction. Okay? Now, circumduction, yes? You see the girls that play fast pitch softball, and the pitcher, she takes that ball and she does this. Right? That's circumduction. Yes, that's circumduction. It's very hard on their shoulder, by the way. Very hard on their shoulder. Right? Now, if you do this, rotate a bone around its long axis, that's rotation. Right? Circumduction here. Right? But rotation is this. Rotation. Right? Okay? Now, we talked in a previous lecture about the atlas axis, right? Yes? So the atlas is a ring, and the axis has a bump on it called the odontoid, and the atlas sits right here and it does this. It's a pivot joint and it pivots around. That's rotation. Okay? Okay, some special movements, right? Some special movements, yes? Your hand. Palm up, supination. Palm down, pronation, right? How do you remember that? Because if you do this, right, you can slurp your soup. Yes? That's supination. Your soup, right? If you do this, that's pronation, right? Supination, pronation. Supination, soup. Pronation. That's the difference, right? Supinate, pronate, right? Okay? Of your hand. Okay? The foot, right? Sorry, she came undone. These are more for fashion than really. Anyway, the foot, if it comes up, that's dorsiflexion, and you push down, it's plantar flexion, right? Dorsiflexion, and this is the what surface? Plantar. Push it down, that's plantar. Plantar flexion. Dorsiflexion, plantar. Yes? If I stand on my tiptoes, right? Plantar flexion, right? If I walk on my heels, dorsiflexion. I'm dorsiflexing my feet, right? Okay? Say that again?
Like a ballerina.
Like a ballerina, there you go, okay? Right? Again, the ankle, yes? Okay, it's very common to, let's see, it's very common, you step down and the ground is unlevel, and your foot goes in, and you sprain your ankle. That's inversion sprain, right? Conversely, you step here and the foot goes out like that. That's eversion. Inversion, eversion. Inversion, eversion. Okay? Inversion, right? The middle of the foot is turning in. Eversion, it's the outside of the foot is turning out. Inversion versus eversion, right? Okay. 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 The jaw, right? The jaw. You stick it out, protraction, you pull the jaw back, retraction. Protraction, retraction, right? Out and in of the jaw. Retract, that makes sense. Pulling it back, retraction, okay? Okay, by the way, okay? Maxilla, mandible, the mandible fits up in there. There's a little disc in there, right? This joint is very easily, sorry, that's how I broke it in the first place. It's very easily dislocated. It's very easily. Have you ever opened your mouth and then I can't shut it? Okay. Very common for this to kind of slide forward a bit, right? And the jaw's open and you can't shut your jaw. It's very painful, right? Yes? Supposedly the book claims it's the most easily dislocated joint in the body is the jaw. Okay? Now, what do you do for that? What you do for that is, I can't hold them both at the same time. You stick your thumbs in their mouth, here, and you push down and you rotate it up to pull the jaw down and twist it up in there. And that's, that's what you do for that if they dislocate that. Yes? Okay. Dislocate the jaw. Okay. Okay. Now, we need to talk about, we said, hey, you're not supposed to be talking when I'm talking, right? Don't do that again. Okay? Not allowed. Totally. Zero, zip, zilt, nada. Null. Right? Okay. Now, synovial joints. Okay? How many of you are going to take the HESI test? Right? I'm telling you. This figure 8.7, these types of synovial joints is on that test. Okay? They're going to ask you several of these. Okay? Number one. Okay? Book says plane joint or gliding joint, right? For one joint surface slides across the other, a gliding joint or a plane. This plane versus that plane, right? A gliding joint. And that is the wrist we were talking about earlier, a gliding joint. Number two, super simple, the elbow. The elbow is a hinge, just like a door, right? Right? The elbow is a hinge joint, yes? The knee's a hinge, right? It does this, it stops, it does this, right? It's a hinge, yes? Now, okay. Now, if you can see the radius and the ulna right here, okay? Right? This is round. The radius is round. The ulna is the big one. The radius is a small one. but the head of the radius is in a ligament. It's shaped like this, it's round, and that ligament does, and when you do supinate or pronate, that's a pivot joint, okay? Right? Powerful ligament holds that in place, and it allows you to supinate or pronate. Yes? Okay? Because right up in here you have that. By the way, ladies, right? Little children, let me see this arm here. Little children, come on, let's go, right? Little children, that ligament around the head of the radius is not always formed yet, or it's not always tight, and you can literally do this. Pull it out of that, okay? It's called pulled arm syndrome from jerking the kid. Come on, let's go, right? And such. I've only had like one of those in 35 years, but I guess it's common. And so what you have to do is you have to, hopefully you can manipulate it, right? So what I did was, brought the little girl to me. She's like 5 years old, okay? And so what I had to do was, turned her palm up, got my thumb right there on the head of the radius, and I did this, and I worked it as I shoved, and I pushed like that, and I shoved it back up in there, okay? And when you get it back up in there, almost immediately, they walk in like this, my arm hurts. But when you get it shoved back up in there, almost immediately it doesn't hurt them anymore, okay? Took me about 15 minutes, right? Well, it was about 6 months later, guess what? They showed up again, same thing. The second time, I swear I worked that for an hour, just right before I got it all the way up in there, right? And then as the little girl grew and the head of the radius got bigger and it was tighter, it never happened again, okay? But you got to be careful because it's common, little children dawdle, right? Yeah, come on, let's go, come on, hurry up. Yeah, get in the car. Yes? So you got to be careful with that, okay? But that is a pivot joint, right? It pivots around one point. Oh, by the way, atlas axis, right? Yes, you got your ring around it, the atlas, right? The axis in the atlas does this, so you can turn your head. Most of your rotation of your head comes from atlas axis, that one joint there, okay? Right? That's very critical, okay? That's a pivot joint. Next, condylar joint, yes? Okay? If you look on the bottom of the skull here, right? Okay? Here and here are the occipital condyles. Okay? It's what makes contact with and articulates with the atlas, right? And they're curved, right? My point being the end of a bone that's kind of shaped like that, right? And articulates with another bone, that's a condyle. Oh, by the way, this right here, that's a condyle. That's a condyle. There or there. Okay? So, the book, example in the book is our fingers, condylar joints, right? Okay? Now, the thumb. The thumb is very unique, right? Because we can go like this, we can go like that. We can make tremendous movement with that thumb, okay? And it's a saddle joint. It's very unique, right? If you look at a saddle from the side, right? If you look at a saddle from the side, it's curved this way. Yes, here's the saddle horn. Here's the isn't it called the cantle, those of you that are cowboys, right? But if you look at it from the front, a saddle looks like this, right? Cowboy's legs go here and here around it, see? So, a saddle joint is not only curved this way, it's also curved that way. And that's so you can do this, but you can also do that and this. Very unique joint, the saddle joint, okay? Saddle, cowboys and Indians, saddle, right? Yes? And then very simply, everybody knows this one, the ball and socket, right? Your shoulder's a ball and socket, your hip's a ball and socket, right? But ladies, I'm telling you, if you're gonna take that test, they're gonna ask you one or two of these joints, okay? Gliding joint or a plane joint, a hinge joint, a pivot joint, condylar joint, ball and socket, or the unique saddle joint, okay? Okay. That's very important. Probably on your final, I'm going to ask you that. The knee is a what? And you're going to go, oh, that's so easy. It's a hinge joint, right? The knee or the elbow, they're hinges. Okay? Okay. Now, let's look at the knee from the side and talk about the anterior and the posterior cruciate ligaments, okay? Anterior and posterior cruciate ligaments, yes? Okay? Now, here we go. Okay? If we take the knee and we look at it, okay, kind of, okay, it's a little more scooped out. Okay? Shaped like that. We have, I'll do them in different colors. We have a ligament that goes from the front of the tibial plateau and it attaches up here to the back. Okay? That is the anterior cruciate ligament, ACL. Now, we have another one that attaches back here and attaches up here, okay? That is the posterior cruciate ligament, the PCL, okay? This is a lateral view, L-A-T-E-R-A-L, from the side. This is looking at it from the side, okay? Note, we name the ACL and the PCL from where they attach on the tibia. This is the tibia, right? This is the femur, right? Now, anterior up here, posterior back here, yes? Now, again, we name them from where they're attached. If you think about it, okay, the knee joint is a hinge, right? And the anterior cruciate ligament here, right? When the knee goes like this, it stops motion. Remember, ligaments limit motion, right? So the anterior cruciate ligament does not allow the tibia to do this. It's not supposed to do that, right? Conversely, the PCL, because its attachment as the lower leg moves back, this becomes taut. If the lower leg moves forward, this becomes taut, right? So the ACL doesn't allow your tibia to do this. The PCL doesn't allow it to do that. Which is injured more commonly, the ACL or the PCL?
ACL.
ACL, almost always. And we talked about it's much more common in ladies, especially basketball. And when can it happen? It can happen when you hyperextend the legs, kaboom, like a football player, lineman. It can happen, basketball, you run down the court and you stop and then you twist and your foot is planted. You can snap it that way. Basketball, you run and you stop suddenly and then you jerk this way or that way. And if your foot, yes? Do you have personal experience? Yes?
Yes.
Okay. You want to enlighten us? Or no?
Well, I mean, I was doing basketball drills and we were doing ball handling and I stopped and pivoted my foot. And when I changed directions, I tore my ACL and my meniscus.
Yes. I'm guessing it was painful?
Yeah.
Oh,
Well,
man.
at first I didn't know. I thought it just like kind of like sprained it and then I.
Okay. Did you have to have surgery?
Yes.
Yes?
I had 2 surgeries. winter
Okay.
with the ACL and then my meniscus.
Okay, let me explain. It's called a cruciate. Cruciate is the word for, right, cross, cruciate. Yes, because the ligaments are like this. Okay, anterior and posterior. Yes, and that's where cruciate means, right? Cruciate means cross, actually. Yes. Okay, so anterior, and again, we name them by where they attach on the tibia. That's why this is the ACL, anterior, this is the PCL. Much more common to that. If your leg is stiff and it twists, or if your leg is bent a little bit and you can really twist it. It's bent and then it's twist, and anyway, the ligament becomes taut. Okay, we've already talked about that. When the knee gets totally extended, right? Right, then the popliteus cranks it, and it's very taut. It's very tight. It's a very solid, powerful joint. Okay. Okay, and again, we talked about how when you go up for the rebound, when you jump, men have a tendency to bend their knees, and ladies land much more stiff-legged. And especially if that foot is twisted in or out a little bit, and you come down on it, it can snap that ACL. And studies do show, ladies, at the time of the month that you're having your cycle, boom, you're more likely to tear the ACL. Okay? Okay. Just a little bit more because I'm getting tired. I don't know about you guys, I'm getting tired. Okay? Okay. Glenohumeral, right? The glenohumeral joint. Yes? Shoulder blade coming across, right? You can't see it, but on the back side you got the spine, right? You got your head of your humerus right here, yes? Right? And remember, this is called the glenoid fossa, and you got cartilage in here. This is called the glenoid labrum, right? And this is shaped like a ball, and that cartilage is like half of a ball. So that way it fits in there just like that. Common to get torn. Ladies, volleyball, there. Or my friend Cynthia Howe, her son Ryan, they do push-ups in the Marine Corps. And that's how he tore his, right? And so it's the glenoid labrum, right? Now, here's the thing. The most freely movable joint in the body is your shoulder, right? It's amazing. You can do this, 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 right? Yes? But because it's so freely movable, guess what? It's not stable, right? If you have a joint that doesn't move very much at all, it's very stable. Conversely, you have a joint with a big, huge range of motion, okay? And that huge range of motion causes the joint to be unstable, right? Okay. What else do I need to talk about? Okay. Right? Let's talk about the rotator cuff. ROTATORCUFF. All right? Rotator cuff. Basically, let me take me 1 second. Okay? The rotator cuff is made up of supraspinatus, infraspinatus, teres minor and subscapularis. There we go. S-C-A-P-U-L-A-R-I-S. Let me explain. Basically, the rotator cuff, you got 4 muscles, and they attach to the humerus right here. Yes? And because of those 4 muscles, we can go up, down, around, this way, that way, because these 4 muscles, right? And it's very common, so many people, what happened? Oh, I tore my rotator cuff, right? Tore the rotator cuff, right? Okay, so let's talk about where these attach, okay? If I can get this guy to cooperate. Yes? Okay. This is the spine of the scapula, right? Coming across. Supra, like super, above. Supraspinatus attaches there. Infra attaches here, below the spine, right? Right across here, teres major and minor across here to the back of the arm. Now, subscapularis, right, up under there, that's where it attaches, right? Those are the 4 muscles. They actually call it the sits, S-I-T-S, supraspinatus, infraspinatus, teres minor, and subscapularis, okay? Okay? S-I-T-S, the sits muscles, right? It's very common. Now, if you have a tear, it's very painful and it may limit your range of motion. Yes? Okay? Now, if you have a partial tear, generally you can do PT and you do not have to have surgery and it will heal up. If you have a total tear, for instance, I had a fellow, an older gentleman, and he's walking along, right, and he falls in literally a 6-foot hole. That's how deep it was. And his body fell in the hole, only his arm was up here. Can you imagine what it did to that shoulder? And it was very painful, and he showed up at my office, and I checked him a little bit, and I'm like, I think you have a total tear, man, a total tear. And such, so I think you need to go to an orthopedic surgeon. So he went to the orthopedic surgeon, total tear, had to have surgery and stitch it back together, right? Now, let's talk a little bit about that. If you got to have shoulder surgery, you need to do that within about 90 days, okay? If you wait longer than 90 days, then that muscle is going to get what's called fatty infiltration. Right? Fat will grow in there, and you'll never have near as good a results as if you have it done within the first 90 days. Okay? So, if you have a total tear, have it fixed. You know, that's what I told this guy. No, I can't help this. I think you need to go to the guy, orthopedic surgeon, Dr. Legan over there at Dumas, fixed his shoulder real nice. Right? And such. Okay? But anyway, the other thing is that as we get older, the acromion right up here, supraspinatus tendon goes, well, you can't see it because you're sitting way back there. Supraspinatus tendon goes right underneath there, right? Supraspinatus, that's the muscle, and as it goes under here, it turns into a tendon, then comes down and attaches, right? As time goes by, this is the acromion we talked about, and the acromion is curved like that, and when you're a little kid, you go hanging on the monkey bars and this and that, and when you're an adult, you don't generally do that, right? And so in time, that bone does that. In time, that supraspinatus tendon gets thicker and fatter. Okay? So, with the bone comes down and the tendon gets thicker and fatter, and you get impingement syndrome. It's very common in 45, 50, 55, 60-year-old men. It's very common. Okay? Impingement. Right? Now, it can come on suddenly. I had a guy that was a roper. Whoa. They whip that rope forward and then they jerk their hand back, snap it, right? At the XIT 1 year I treated, yes, and such. But anyway, more commonly, it's an older guy. I had a guy in my office today with this, been hurting him for 6 months, and truck driver, changing gears, right? For 30 years, grinding them gears, yes. And so he was having a lot of impingement in here. Now there's exercises for that I always put them on. I even had a little bit of that myself, okay, and such. But anyway, it's very common impingement, and you have to give them some exercises. If they do it at home, it'll get way better, right? One of the reasons that tendon gets thicker, though, is this. In fact, this weekend I watched about a 20-minute video about it, very interesting. People that are diabetics, or people that are insulin resistant, their blood sugar runs high or their insulin is high. And what happens is tendons thicken. Okay? Tendons thicken. And a tendon, normally, you're going to have all these fibers that are real parallel. Yes? Right? And tendons are very, very strong. Think about, have you seen that glass tape? It's clear, but it has those fibers through it. That tape is very strong, okay? And that's kind of the way tendons are. But what happens is, this gets thicker and it becomes disorganized, right? And such, and it becomes weaker. So, I don't know, I think it's 2 more chapters. We'll talk about how you pop that Achilles, right? You pop that Achilles. Who normally pops his Achilles tendon? What kind of a person? Describe a person that commonly is going to pop his Achilles tendon.
A runner.
A runner, okay.
Basketball player.
A basketball, okay. Basketball is common to cause it, but no, it's basketball. But let's talk about it, right? Usually what happens is this. The people that pop their Achilles tendon are usually men, and they're overweight, and they're 55 years old, right? And they were really good athletes when they were in high school, right? Maybe they were basketballers, but they haven't played basketball for years, right? And their kids become teenagers, and they get out there and they think they can play basketball with the kids, but they're overweight. And by the way, they're probably insulin resistant or diabetic. And that Achilles tendon is not near as strong as it used to be. And they run around and jump and cut. Sometimes you can even hear it snap. And that tendon tears. Right? Mega pain. That's what I've heard. Mega pain. I don't know. But anyway, yes, it's very common. But the typical person who snaps his Achilles tendon is a late middle-aged guy who's overweight. He's probably either a diabetic or pre-diabetic. That's why his ligaments and his tendons are not as strong as they used to be, right? And he thinks he can get out there and hustle it and run. Yes, right? And not a good idea. Not a good idea, okay? So that's the common person, yes, that does that. And I forget what they said, but the amount of people that were either diabetics or pre-diabetics, right, is very high that have this injury because the tendons. Okay? Now, are you going to have surgery for that? Okay. Normally they put you in a boot and you're in the boot for 6 months, and then little by little you start putting weight on it, right? Because that tendon will knit back together itself. However, if you're in the NBA and you're making $10 million a year, yes, they're doing surgery on you immediately. But most people, no. The results are just as good if you put them in the boot, give them painkillers, and they let it heal up over 6 months. But if you're making $10 million, yes, they're doing surgery immediately, right? They may even put some cadaver tendon in there. But anyway, okay? Okay. All right. Well, okay, start studying for your test, okay? Start studying for your test. We talked about basically what's on it. Okay? And remember, it's a big, long test, and don't be upset if you read a question and you just don't know. But remember, try to eliminate 2, and then pick out of the other 2. Okay? Capital letters in the blank. You just be circle A, B, C, D, that's not going to cut it. Okay? Okay. See y'all tomorrow. Have a good evening. Thank you. Now, 2,